Hello everyone, today we'll be discussing breast cancer. Breast cancer is the most common cancer diagnosed in women and the second most common cause of death from cancer among women worldwide. So this cancer accounts for more than 1 in 10 new cancer diagnoses annually. The breast appeared glands of variable size and density that lie superficial to the pectoralis major muscle. They contain milk-producing cells arranged in lobules. Multiple lobules are aggregated into lobes with interspersed fat. Milk and other secretions are produced in acini and excreted through lactiferous ducts that exit at the nipple. Breasts are anchored to the underlying muscular fascia by Cooper ligaments, which support the breast. Breast cancer most commonly arises in the ductal epithelium, but can also develop in the lobules. However, in much of the developing world, a breast mass or abnormal nipple discharge is often the presenting symptom. Breast cancer is diagnosed through physical examination, breast imaging, and tissue biopsy, which we call the triple biopsy or triple assessment. Treatment options for breast cancer include surgery, chemotherapy, radiation, hormonal therapy, and more recently immunotherapy. We will discuss the above treatment options in details later. So what are the risk factors for breast cancer? We talk about the age. So the age-adjusted incidence of breast cancer continues to increase with the advancing age of the female population. Gender, so most breast cancers occur in women. Personal history. A history of cancer in one breast increases the likelihood of a secondary primary cancer in the contralateral breast. So if there is a history of you having breast cancer on the right side, there is a high chance of you developing in the left side as well. Histologic. So histologic abnormalities diagnosed by breast biopsy constitute an essential category of breast cancer risk factors. Family history and genetic mutations. So first-degree relatives of patients with breast cancer have a twofold to threefold excess risk for the development of the disease. Genetic factors cause 5 to 10% of all breast cancer cases, but may account for 25% of cases in women younger than 30 years. Then BRCA1 and BRCA2, which is the BRCA1 and BRCA2, these are the most important genes that are responsible for increased breast cancer susceptibility. Then reproductive. So reproductive milestones that increase a woman's lifetime estrogen exposure are thought to increase breast cancer risk. These include the onset of menarche before age of 12 years, first live childbirth after the age of 30 years, nulliparity, and menopause after the age of 55. Then exogenous hormone use. So therapeutic or supplemental estrogen and progesterone are taken for various conditions, with the most common scenarios being for contraception in premenopausal women and hormone replacement therapy in postmenopausal women. Then when we talk about other factors, so radiation, environmental exposure, obesity, and excessive alcohol consumption are some other factors that are associated with an increased risk of breast cancer. So now we go and discuss the pathophysiology. So most breast cancer is sporadic, which is 90 to 95%, with only 5 to 10% of patients having an identifiable genetic mutation. BRCA1 and BRCA2 are the most common associated genetic conditions. Invasive ductal and invasive lobular carcinoma are the most common pathologic forms of invasive breast cancer. Carcinogenesis usually occurs due to a complex interplay of genetic and environmental risk factors, hormonal influences, and patient-related factors. The pathogenesis, treatment, and prognosis are closely associated with the following molecular subtypes of breast cancer. So these are the molecular subtypes of breast cancer, which is the luminal A, luminal B, basal-like, and HER-enriched. So when we talk about luminal A, that is hormone receptor positive, human epidermal growth factor receptor, which is HER2 negative. So in this one, hormone receptor will be positive, however the HER2 receptor will be negative. Then luminal B, this is where the hormone receptor will be positive as well as HER2 will be positive. Then basal-like, where hormone receptor and HER2 both will be negative. Then HER-enriched is where HER2 will be positive and hormone receptor negative. So what we need to know about these subtypes is hormone receptor positive tumors, which are the luminal A and luminal B. They tend to be less aggressive with improved survival rates. Then HER2 enriched tumors are generally more aggressive. They have a poor prognosis without targeted therapy. Then, in the era of targeted anti-HER therapy, which is trastuzumab, the paradigm has shifted, okay? So, basal-like tumors are negative for the molecular markers and they tend to have a worse prognosis with poor survival rates. Then now we go to the histopathology. So, invasive breast cancer is characterized by the invasion of neoplastic cells beyond the basement membrane that can be morphologically varied, with several subtypes described. The following are the common histologic types of invasive breast cancer: ductal adenocarcinoma. This histologic type comprises 50 to 75% of all invasive breast cancers. Clinically, these tumors are often felt as a breast mass secondary to a significant fibrotic reaction. When you look at it macroscopically, this lesion arises in the terminal duct lobular unit, with abnormal epithelial cells with varying degrees of atypia. These cells invade the basement membrane, however, there are no pathognomonic histologic features of invasive ductal carcinoma. Lobular carcinoma. Invasive lobular carcinoma makes up 10 to 15% of breast cancer and tends to permeate the breast in a single file nature. So this results in tumors that typically remain clinically occult, escaping detection on mammography or physical examination, only until the disease becomes extensive. A discrete mass is seldom palpated. Multifocal tumors and bilateral disease are more common with invasive lobular carcinoma. And characteristically, these tumors stain negative for E-cadherin. Then we go to mucinous carcinoma. So these are also known as colloid carcinomas. These tumors make up 2 to 5% of breast cancers. They are well demarcated in older women and they are typically characterized by mucin production. Tubular carcinoma. This is microscopically characterized by infiltrating cells with minimal atypia that form small glands and tubules. 1 to 2% of breast cancers are among this subtype. Then we have medullary carcinoma. These aggressive tumors are poorly differentiated and are seen more commonly in BRCA mutant and younger patients. History and physical examination. So what we need to know is that most breast cancer patients are asymptomatic and lesions are discovered during routine breast examination or screening mammography. With increasing size, the patient may notice a palpable lump. Breast pain is an unusual symptom that happens about 5% of the time. More advanced disease may present with symptoms that include pure d'orange, frank ulceration, axillary lymphadenopathy, or signs of distant metastasis. Then inflammatory breast cancer, which is an advanced form of breast cancer, may have clinical features similar to breast abscess, which is swelling, redness, and other local signs of inflammation. A thorough physical exam is a vital part of the clinical assessment for breast cancer. Both breasts must be examined in the sitting, standing, and supine positions, with the arm in the following positions: so arm abducted, extended, and externally rotated. Palpation, overlying skin changes, nipple discharge edema, pure d'orange, and ulceration should be taken note of. So as you can see on the diagram on the side, these are the skin changes that you can possibly notice. Then careful palpation of the regional lymph node basins for lymphadenopathy is also essential. Then this is just a short chart that's showing the 6 steps of performing a breast self-examination. This is done to prevent or early detection of breast cancer. So now we go and discuss the triple assessment. So triple assessment for breast lump is standard practice and the robustness of assessment towards the diagnosis of breast cancer is crucial. So we use the following modalities, so which is physical examination, imaging, which involves mammography and ultrasound, and a fine needle aspiration cytology, which we call a FNAC. So this is more accurate than any of the modalities used alone. Then on evaluation, we discuss diagnostic breast imaging. Mammography is the most commonly used modality for screening and diagnosis of breast cancer. Abnormal findings on mammography include mass lesions, calcifications, or architectural distortion. When identified on screening mammography, diagnostic mammography, which utilizes higher quality imaging with several views, is indicated. However, we need to know that mammography is of limited utility in patients with dense breasts, in younger patients, and in those who cannot tolerate the breast compression that is required. So in this case, breast ultrasound or MRI with contrast may be utilized. What we need to know is that breast ultrasound is actually similar in sensitivity to mammography, and it can be used to obtain image-guided biopsy. Then indications for MRI of the breast include axillary lymph node disease and an occult primary malignancy, Paget disease, multifocal or bilateral cancers, neoadjuvant chemotherapy treatment response assessment, and high-risk patient screening. So breast imaging findings are classified by the breast imaging reporting and data system, which we call the BIRATS category, which correlates imaging findings with their probability of underlying malignancy and recommends a broad treatment strategy. So we need to know that the BIRATS categories range from 0 to 6. So this is whereby stage 0 is whereby findings are inadequate, 1 is negative, 2 benign findings, 3 probably benign findings, 4 suspicious, which can be subdivided into 4A, 4B, and 4C. BIRATS 5 is highly suggestive of malignancy, and 6 is biopsy proven. So when we look at stages 4 to 6, that's where the chances of cancer are high, okay? From stage 0 to 3, it's less than 2%. Tissue biopsy. So once a suspicious lesion is identified, tissue biopsy with stereotactic corneal biopsy is performed with imaging guidance. Corneal biopsy is superior to fine needle aspiration and should be performed whenever possible. In patients with clinically positive regional lymph nodes, an ultrasound-guided corneal biopsy is performed. Staging imaging. Routine lab investigations and imaging for systemic disease are not recommended for operable breast cancer in the absence of symptoms. If associated symptoms are present, an MRI brain, chest CT, bone scan, or CT of the abdomen and pelvis may be performed. Baseline complete blood count and comprehensive metabolic panel that includes liver function tests are indicated if neoadjuvant chemotherapy is planned. Then for clinically advanced breast cancer, which is inflammatory breast cancer with chest hollow skin involvement and bulky axillary lymphadenopathy, a chest, abdomen, and pelvis CT along with a bone scan is recommended to be performed. Then we go to treatment or management. Breast cancer treatment is nuanced and based on various factors including the disease stage, pathology, patient preference, and available resources. In general, breast cancer management approaches are divided into early breast cancer, locally advanced breast cancer, and metastatic breast cancer treatment. When we talk about early breast cancer, so this includes tumors which are less than 5 centimeters in size without clinically positive lymph nodes. Treatment involves surgery, chemotherapy, radiation, and hormone therapy. This depends on the stage and the molecular profile, and the modalities used include surgical treatment, which is options to excise the primary tumor, which include breast conservative surgery, which is a partial mastectomy or lumpectomy or a total mastectomy. Then axillary lymph node management, sentinel lymph node biopsies performed during the operation without extranodal extension. No further axillary surgery is required if 2 to 3 axillary lymph nodes are microscopically positive. A completion axillary dissection or axillary radiation is indicated in patients with more than 3 positive lymph nodes or extranodal extension. Chemotherapy. Systemic chemotherapy is indicated based on the final stage and the tumor's molecular profile. So we need to know in hormone receptor positive tumors, the decision to initiate chemotherapy is based on the risk stratification. High-risk patients benefit from chemotherapy in addition to hormonal therapy. Then all HER2 positive patients with tumors more than 1 cm should receive anti-HER2 directed therapy. And all triple negative patients with tumors more than 1 cm should receive systemic chemotherapy. Radiation. Patients that undergo breast conservation surgery must receive radiation to the breast with a boost to the tumor bed to reduce local recurrence. Patients who undergo mastectomy do not need breast radiation except in certain circumstances, such as if the tumor is more than 5 centimeters. These chest wall invasions can involve a multifocal tumor or more than 4 positive nodes. Hormone therapy. Anti-estrogen or aromatase inhibitor therapy is indicated in all hormone receptor positive patients. Upfront chemotherapy has been increasingly used in early-stage triple-negative and HER2-positive tumors. Delivering the chemotherapy upfront has several advantages, which include allowing response assessment, a greater likelihood of completing chemotherapy, and an increased likelihood of breast conservation therapy. Then we now go to locally advanced breast cancer. Locally advanced breast cancer primarily consists of tumors that are larger than 5 centimeters or those with clinically positive lymph nodes. Most patients with LABC will receive some form of neoadjuvant therapy with some adjunct surgery and radiation therapy. The primary tumor and the involved lymph nodes must have radiographically detectable markers placed before initiation of chemotherapy, as tumors can shrink and disappear after therapy. Chemotherapy regimens vary based on the tumor pathology, such as hormone receptor positive, HER2 positive, or triple negative, the patient's age and physical status, and locally available resources. So we need to know the goal of upfront chemotherapy are to reduce the size of the primary, eradicate micrometastatic disease, and assess disease biology based on the responsiveness of the tumor to chemotherapy. After completion of the chemotherapy regimen, breast and axillary imaging are repeated to assess response to chemotherapy and determine further management. These include surgical treatment, which is options to excise the primary tumor, including breast conserving surgery or total mastectomy. Contraindications to breast conservative surgery include large tumors, chest wall or skin involvement, multifocal disease, inability to receive radiation, and a large tumor size to breast size ratio. Axillary lymph node management. So in patients that have a clinically positive axilla at diagnosis, an axillary dissection is always performed, regardless of the response of the tumor to neoadjuvant chemotherapy. Then in patients with a clinically negative axilla, sentinel lymph node biopsy is performed at the time of surgery. At least 3 lymph nodes should be harvested using a dual tracer technique. Then patients with residual disease should undergo a complete axillary dissection or axillary radiation. Systemic chemotherapy. So patients with residual disease after systemic chemotherapy may benefit from additional chemotherapy based on the molecular characteristics. Radiation therapy. So the indications of radiation are similar to breast conserving surgery. Hormonal therapy. Anti-estrogen or aromatase inhibitor therapy is indicated in all hormone receptor positive patients. Metastatic breast cancer. Metastatic breast cancer is managed primarily via systemic therapy. Chemotherapy, targeted therapy, immunotherapy, and hormonal therapy. These are all options. Now, depending on the molecular profile and patient fitness, palliative radiation may be used in controlling bulky primary disease and metastasis to the brain, bone, and lung. Surgery is generally not recommended for metastatic breast cancer, except only for symptom control and palliative therapy. Surgical oncology. Here we're going to discuss the various surgical options that we have for breast cancer. So surgery plays a central role in management of breast cancer. With the increased use of highly effective chemotherapy and targeted therapy, operations have become less extensive and morbid. While survival has improved, in current practice, surgery helps manage the primary tumor and provides essential staging information. Breast conserving surgery can be performed in most patients with tumors that are less than 5 centimeters, provided that the breast is large enough for a cosmetic result. Mastectomy is indicated in large primary tumors, tumors invading the skin or chest wall, multifocal cancers, inflammatory breast cancer, and in patients who are unable to have radiation. Sentinel lymph node biopsy is a vital staging procedure in patients with a clinically negative axilla. Those with 1 to 3 positive lymph nodes on sentinel lymph node biopsy and without gross extranodal extension can safely avoid axillary lymph node dissection. Patients with clinically positive axillary nodes typically require an axillary lymph node dissection. And the following are the primary operations that are performed for breast cancer and in the axilla. So partial mastectomy or lumpectomy. Partial mastectomy or lumpectomy involves the excision of a portion of the breast tissue with a margin of healthy tissue. The incision can vary based on the location of the tumor and the desired cosmesis. So a typical incision that you can make are circumareolar, radial, or along the breast skin crease. Partial mastectomy is the centerpiece of breast conserving surgery, allowing for the conservation of most of the breast. Now, the cosmetic result depends on the amount of breast tissue removed compared to the remaining breast tissue and nipple preservation. For non-palpable lesions, the lesion must be localized preoperatively, usually with a wire or radioactive seed, to ensure the removal of the entire tumor. Simple mastectomy and nipple-sparing mastectomy. Simple mastectomy involves excision of the entire breast and nipple areolar complex. Then the leg pectoralis major fascia is removed as well. A nipple-sparing mastectomy is a relatively recent modification of the simple mastectomy, in which the nipple areolar complex is spared and the breast tissue is excised through a small circumareolar incision. The cosmetic result of reconstruction are superior to a conventional mastectomy, with a slightly increased but acceptable poorer oncologic outcome. Modified radical mastectomy. So this combines the simple mastectomy technique with axillary lymph node dissection. The mastectomy incision is usually extended for the axillary contents to be removed. Radical mastectomy, which includes the removal of the pectoral muscles and sacrifice of the nerves, is seldom performed. Then axillary sentinel lymph node biopsy and axillary lymph node dissection. The axillary lymph nodes drain much of the ipsilateral breast and are divided into 3 levels by the pectoralis minor muscle. A radiotracer or blue dye is injected near the primary and 1 to 3 lymph nodes in the axilla that have the highest uptake of radiotracer, or are blue, are excised. When done with a lumpectomy, the same incision can sometimes be used, or a separate incision at the axillary hairline may be required. Axillary lymph node dissection involves the removal of all the fibrofatty and lymphoid tissue in levels 2 and 3, with preservation of the long thoracic nerve and thoracodorsal nerve. Radiation oncology. Radiation therapy has a significant role in local disease control, primarily in the adjuvant setting, but may also be used for palliative therapy. In early-stage breast cancer, adjuvant radiotherapy has been shown to reduce the risk of breast recurrent disease by approximately 50%. Modalities to deliver adjuvant radiotherapy include external beam radiation, brachytherapy, or a combination of both. Medical oncology. Chemotherapy, hormone therapy, immunotherapy, and targeted therapy are the systemic therapies used in breast cancer management, and they are described below. Cytotoxic chemotherapy is used in the neoadjuvant and adjuvant setting. Chemotherapy is most effective in high-grade poorly differentiated tumors that have a high cell turnover rate, such as triple-negative and HER2-positive tumors. The chemotherapy regimen depends on tumor characteristics, the patient's ability to tolerate chemotherapy, and the degree of potential benefit. Adjuvant chemotherapy is associated with improved overall survival, disease-free survival, and reduced local recurrence. Cyclophosphamide, methotrexate, and 5-fluorouracil combination was one of the early regimens used in the adjuvant treatment of breast cancer. Adjuvant chemotherapy is recommended for most patients with triple-negative and HER2-positive tumors that are above the T1 stage. Targeted therapy. Anti-HER2 therapy is indicated in 17% of breast cancers that overproduce the growth-promoting protein HER2/neu. Trastuzumab, which is the first approved drug, is a monoclonal antibody directly targeting the HER2 protein. PARP inhibitors such as olaparib and talazoparib are monoclonal antibodies that prevent the activation of PARP, which are DNA repair enzymes. Then CDK4/6 inhibitors such as palbociclib target the CDK4/6 proteins which promote cell division. Immune checkpoint inhibitors pembrolizumab, nivolumab act on the PD-1/PD-L1 pathway to activate the host immune system. Hormonal treatment. Selective estrogen receptor modulators such as tamoxifen or aromatase inhibitors such as exemestane and letrozole are indicated in HR-positive breast cancers. Estrogen receptor modulators are especially indicated in premenopausal women, while both drugs can be used postmenopausal. Hormonal therapy reduces the risk of breast cancer recurrence and mortality and is indicated from 5 to 10 years. Premenopausal women may also benefit from oophorectomy or chemical suppression of the ovaries, which are the primary source of estrogen before menopause. Staging of breast cancer. Breast cancer staging is determined clinically and histologically. Clinical breast cancer staging is based on physical examination and imaging studies before treatment. Histopathologic breast cancer staging is determined by pathologic examination of the primary tumor and regional lymph nodes after definitive surgical management. Staging is performed to group patients into risk categories that define prognosis and guide treatment recommendations for patients with a similar prognosis. Breast cancer is classified with the TNM, which is the tumor, lymph node involvement, and metastasis TNM classification system, which groups patients into 4 stages based on the primary tumor size, the regional lymph node status, and if there is any distant metastasis. Primary tumor, so TIS, this is carcinoma in situ. T1, where the tumor is less than 2 centimeters. So 1A is the tumor is 0.1 to 0.5 centimeters. T1B tumor is 0.5 to 1 centimeter. T1C tumor is 1 to 2 centimeters. Then T2, this is where the tumor is 2 to 5 centimeters. T3 tumor is more than 5 centimeters. T4, so T4 is divided into A to D. T4 is where there is chest wall involvement. T4B, the skin involvement. T4C, both 4A and B, which is there is chest wall as well as skin involvement. T4D, inflammatory cancer. Then regional lymph nodes. N1, mobile ipsilateral axillary nodes. N2, fixed matted ipsilateral axillary nodes. N3 is divided into A, B, and C. So A is where there is ipsilateral infraclavicular nodes. 3B, ipsilateral mammary nodes. 3C, ipsilateral supraclavicular nodes. Then M, once you get to M, that is for distant metastasis. So breast cancer staging. So stage 0 comprises ductal carcinoma in situ and non-invasive breast cancer. Early invasive cancer includes stage 1, 2A, and 2B. Stage 3A, 3B, and 3C primarily involve locally advanced disease. Then stage 4 is all metastatic breast cancer. Prognosis. So the prognosis of breast cancer depends on the stage. Stage 0 and stage 1 both have a 100% 5-year survival rate. The 5-year survival rate of stage 2 and stage 3 breast cancer is about 93% and 72% respectively. When the disease spreads systemically, its prognosis worsens dramatically. Only 22% of stage 4 breast cancer patients will survive their next 5 years. Complications. So the complications of breast cancer, which are surgical complications, then also complications that arise due to treatment. So surgical complications include infection, pain, bleeding, cosmetic issues, permanent scarring, alteration or loss of sensation in the chest area, and reconstructed breast. Then complications associated with chemotherapy, nausea, vomiting, and diarrhea, hair loss, memory loss, vaginal dryness, menopausal symptoms, fertility issues, neuropathy. Then complications associated with hormonal therapy include hot flashes, vaginal discharge, dryness, fatigue, Nausea, importance in males with breast cancer. Then radiation complications include pain and skin changes, fatigue, nausea, hair loss, chronic heart and lung issues, and neuropathy. So that's all about breast cancer. If you like the video, please like, subscribe, and comment. Thank you.